Hello everyone, welcome to a new session in hematology. Today we are going to discuss about introduction to hemolytic anemias. So, hemolytic anemia. So, as the word indicates, lytic means they are characterized by increased red cell destruction. So, because of lysis, which may occur either intravascularly or extravascularly, that we will discuss soon. What will happen? Usually the body will try, that is the bone marrow will try to compensate for these RBC loss. But in hemolytic anemia, because of this inability of the bone marrow to compensate for the loss of RBCs in the periphery, whether it may be an intravascular or extravascular hemolysis, anemia occurs. So, clinical and laboratory findings will be based on two important things: the accelerated destruction of RBC, number two, compensatory marrow regeneration. As you know that the normal lifespan of RBC is 100 to 120 days, whereas in case of hemolytic anemia, it will be as low as 15 days. Okay, fine. Now let us see the two types of destruction the RBC may undergo. One is called extravascular hemolysis and another one is what we call it as intravascular type of hemolysis. Fine. So now let us see about extravascular destruction. See, extravascular destruction means what? Outside the blood vessel. So what is the most common site? The answer is spleen. Fine. That is why spleen is called as the graveyard of RBC. Fine. Yes. Of course, in bone marrow also, this reticuloendothelial system, we have no, what is that, earlier we used to say the reticuloendothelial system, now it is called as mononuclear phagocytic system, which includes the spleen, bone marrow, am I right? Yes, all those things. It will phagocytose the fragmented or senescent, very old RBCs, and the hemoglobin will be released. You know, the hemoglobin metabolism you would have read in biochemistry. The hemoglobin will be break down to form what? Bilirubin. So the patient may present with jaundice. So jaundice is a very prominent classical hallmark feature of hemolytic anemia. So whenever they give you a case scenario based question, jaundice will help you to rule out all other deficiency and bone marrow failure syndromes. Okay? Yes. So because, you know, the bilirubin which is first formed is called as unconjugated bilirubin. The level of unconjugated bilirubin will be increased in the blood. The level of serum LDH, because the RBC is one of the storehouse of lactate dehydrogenase. When RBC get lysed, this lactate dehydrogenase will be released and the serum LDH will be increased. Fine? Yes. And the iron which is released from the heme will be stored in the bone marrow. What about the intravascular red cell destruction? Intravascular destruction means this destruction actually it is a minor pathway. If they ask you out of extravascular and intravascular, what is the major pathway of RBC destruction? Your answer should be extravascular hemolysis. The minor pathway is the intravascular RBC destruction. Here, the hemoglobin is released from the RBC within the blood vessel itself, and it will reaches the systemic circulation. Am I right? It will bind with what is the hemoglobin binding protein called as haptoglobin. So since the hemoglobin is binding with all the free haptoglobin which is present in the blood, the serum haptoglobin levels will be markedly diminished, and this blood enters the systemic circulation. It will reaches the kidney, it will be excreted in the urine. That is why we call it as hemoglobinemia or hemoglobinuria. Okay, the plasma becomes red in color, urine becomes red in color. Fine? Yes. Okay. So, and you can see when you take urine, when you do Prussian blue reaction, you can see hemosiderin deposition, that is Prussian blue reaction. Fine? Yes. So what will be the clinical manifestations of hemolytic anemia? So this session is an introductory session. So in this point, I'm just going to give you a idea, an overview, okay, a gist of what we are going to discuss in the further sessions. Fine? That is hemolytic anemias. Fine. So what are the clinical manifestations of hemolytic anemias? Jaundice. Pallor. You know why jaundice? Because bilirubin is formed. Splenomegaly, because the spleen is the graveyard. Am I right? Gallstones, skeletal abnormalities in severe hemolysis, leg ulcers as in case of sickle cell anemia, dyspnea on exertion, tachycardia and systolic murmurs. Okay, because anemia is hyperdynamic circulation. Fine. Okay, fine. So how the bone marrow will try to compensate for the lost RBC. Okay, because RBC is undergoing destruction, so the bone marrow should try to compensate by bone marrow erythroid hyperplasia and reticulocytosis. I have told you in my first session, reticulocyte count is increased in hemolytic anemia. In iron deficiency anemia, will the reticulocyte increase? Yes. When the patient is responding to the therapy, we can see that the reticulocyte count starts increasing. Fine? Yes. In hemolytic anemia, now let us see what are the peripheral blood findings. Okay, yes. Number one, polychromatophilia, nucleated RBCs. Fine. Then red cell morphology, already I have discussed all the morphologies. I have already discussed what in my special video, that is abnormalities of red blood cells in peripheral smear. Okay, that is why I asked you to please, if you have not, before you start watching the hemolytic anemia video, please go and watch that video, because or else in that I have very improperly organized, well organized manner, I have discussed almost all the abnormalities in peripheral smear. Okay, without that knowledge, if you just watch the hemolytic anemia, you have to by heart each and every word. Okay, fine. Then reticulocytosis I have already told you, and erythroid hyperplasia. Okay, erythroid hyperplasia, there will be a reversal of myeloid erythroid ratio. Fine. Then now let us see what is the extravascular and intravascular hemolysis pathway. See, now let us see here. See, we have the senescent RBC, which will be phagocytosed by the reticuloendothelial cells of spleen. Hemoglobin will be released, which will split to form heme and globin. Globin will from the globin will get the amino acid, which will be reutilized from the next globin. Then heme breaks down to form the protoporphyrin, biliverdin, unconjugated bilirubin. The conjugation takes place in liver. Bilirubin glucuronide will be excreted in the bile. Bile will be activated by some enzymes in the intestine to form urobilinogen and stercobilinogen. Stercobilinogen is responsible for the color of the feces, and the urobilinogen will be absorbed from the GIT, which reaches the kidney, and urobilin, that is responsible for the pigmentation of the urine. And what happens to the iron? Iron will be carried to the iron storage site like bone marrow, and iron will be deposited in the marrow. So this is actually the pathway of extravascular RBC destruction. What happens in case of intravascular hemolysis? The hemoglobin will be formed in the plasma itself, which will combine with the haptoglobin. So the free haptoglobin level will be decreasing. Okay, and the hemoglobin will be excreted in urine, leading to what we call as hemoglobinuria, which will give a positive benzidine test. This question has been asked a few years back in Jupiter. What is the test for hemoglobin? Okay, I think you have already learned in biochemistry. It is the benzidine test. Then hemoglobin will be observed by the kidney tubular cells, and it will be converted to hemosiderin by the tubular cells over a few days, and the tubular cells will shed off, and which will lead to hemosideриnuria, which can be detected by Pearl's Prussian blue reaction. Fine. Now let us see what are the difference between intravascular and extravascular hemolysis. Intravascular hemolysis occurs in blood, extravascular occurs in spleen and bone marrow. Intravascular hemolysis leads to plasma hemoglobin, methymalbumin, all these will be present in intravascular hemolysis because the destruction occurs within the circulation itself. So the ferritin level will be decreased in case of intravascular hemolysis, whereas it will be normal or slightly increased in case of extravascular hemolysis. In both the intravascular as well as extravascular hemolysis, what we will be getting, the unconjugated bilirubin will be high, but to be what more specifically speaking, the serum bilirubin will be very high in case of extravascular hemolysis, whereas serum LDH will be very high in case of intravascular hemolysis. But as of an undergraduate is concerned, just remember in both type of hemolysis, serum LDH, serum bilirubin will be increased, and remember this methymalbumin or plasma hemoglobin, all this will be positive only in case of intravascular hemolysis. And as you can very clearly understand by the mechanism I have explained earlier, the urine hemoglobin and urine hemosiderin will be positive only in case of intravascular hemolysis because the destruction occurs within the circulation itself. Okay, then coming into what are the conditions you will get intravascular and extravascular hemolysis: paroxysmal nocturnal hemoglobinuria, G6PD deficiency, and black water fever caused by Plasmodium falciparum. So these are the three important conditions you have to keep in mind. Okay, because the clinical case scenario which will be given to you for your exam will be based on this only. So based on all these features, they will be giving the serum haptoglobin is decreased. Okay, reticulocyte will be increased in all hemolytic anemia. So no doubt. Fine. Yes. And the iron deposition, the urine have hemoglobin, urine have hemosiderin. So actually this question has been asked 1 or 2 years back in a university exam, that the patient comes with history of dark colored urine, everything. So most of the students have written it's like a G6PD deficiency, but the answer it was like a Plasmodium falciparum malaria. Okay, malaria, that is why I am stressing the word black water fever. Plasmodium falciparum malaria also causes what to say intravascular hemolysis. The patient will have urine hemoglobin will be positive, urine hemosiderin will be positive, LDH will be markedly elevated, serum haptoglobin will be decreased. Okay, so please always try to correlate these findings with the clinical scenarios. Fine. Yes, so these are the differences. So once with this done, let us see what are the classification. I'm broadly classifying it into hereditary and acute. In hereditary, it may be due to defect in red cell membrane. Out of that, the most important one are hereditary spherocytosis and A-beta lipoproteinemia or acanthocytosis, or defect in globin synthesis. We have thalassemia, sickle cell anemia, HBM, HBD, E, Q, L, C. Okay, all these are there we will discuss. And enzyme deficiency, pyruvate kinase, which is very common. And next common enzyme deficiencies, we have the G6PD deficiency, then pyrimidine 5-nucleotide deficiency. Then acute we have immune hemolytic anemias due to warm and cold antibodies. Okay, then fragmentation syndromes like HUS, MAHA, microangiopathic hemolytic anemia, thrombotic thrombocytopenic purpura, disseminator intravascular coagulation, and drugs, oxidant drugs, primacune, dapsone, all these causes hemolysis. Okay, then infections like Clostridium perfringens, Bartonellosis. Okay, this has been asked once in NEET PG. Bartonellosis cause what type of anemia? Actually is hemolytic anemias. Fine? Yes. So these are the things that we will be broadly discussing. So this video is just to give you an overview about what we are going to discuss, what are the general features of hemolytic anemia. With these clues itself, see, if you are listening properly, if you are just keeping these very basic points itself, you can find the right diagnosis from a very complicated case scenario. Okay, it's just remember the basic points. You can answer any questions. Thank you.